So yes, Alexandra Nash is one of our F2s who's recently done some work on just things that have ended up in A&E and when they've come under the surgical team. So she actually just took a month's period and just here is an outline of things that have actually been predominantly their primary presentation, or one of the primary complaints being abdominal pain. So if we have a look here, that actually out of all these 191 attendances, only 2% ended up being an appendicitis. And that's out of about 2,000 attendances in the A&E in the Alexandra Children's Hospital. I'm sure it's different in slightly different areas, but that's just to let you know that actually it's quite a small percentage of what happens and comes through A&E. If we go on to the next slide. Oh yeah, sorry. So then as a proportion of all those patients, so out of those 191 attendances which were just coming in as predominantly abdo pain, obviously there will be a little bit, depending on how they are coded, it won't be 100% accurate, but Alexandra did a really good job trying to figure all those things out. Only 34 of those patients were then reviewed by the surgical team. And this is just for abdo pain, so we may have seen people for other things. But even with that, there's still a really small proportion of patients that end up coming to us. So of those 34, 24 of them didn't actually have anything to do with any surgical complaints. So here you can see is 9% of appendicitis, 3% appendix masses, 6% like bicycle accidents, so it comes under trauma, gynecological, interception, gallstones. So it's just to give you a bit of a flavour of like, actually, when it comes to surgically unwell children, it's not a very big proportion of what is coming through to you guys under the paediatric surgical, in the paediatric A&E, that's what I'm trying to say. Go on to the next slide, please. So I think these are two big headlines that have been in the news recently. So the one on the left hand of the screen is a little boy who presented in Newport in Wales with abdominal pain. From what I can gather, he was not actually seen initially and was discharged with flu, then came in septic shock basically back to the hospital and then was transferred to Cardiff, where unfortunately he died later on. So those are the kind of things I guess we're really trying to avoid. Another one is Martha's a little girl who again had a pancreatic rupture, ended up in one of the London hospitals, and I think she deteriorated at the point, and there was some concern about the management within the hospital and escalating concerns, and again she ended up dying. And I think after her mum and dad have made lots of efforts, there's now something called Martha's Rule, which is trying to being mandatory to be able to have a second opinion if necessary. So I think that's where we're trying to avoid these kind of things and really trying to make sure that we pick these things up when they come in. Next slide, please. So triage, the same as usual, observations. If we can get a weight, it's really helpful for us, actually for everybody, because then we can just prescribe. If we need to prescribe things, it makes it much easier to prescribe things in quick succession, especially if someone's poorly. Urine dips, as usual, making sure that in a female they have BT-HCG. I know different hospitals have slightly different cutoffs about when those are done, but if you just follow your hospital protocols, just make sure those get done. That's really helpful. Analgesia as well. I think that's what previous presenter was talking about. It's really important getting some analgesia. It can be difficult if they're vomiting, so getting analgesia into a child who is reluctant or vomiting can be very difficult. So I would say consider IV if that's something that you would, but sometimes I know that's a little bit further along the line once they've got their access and things. Another thing is just being mindful of history of trauma. We'll go through this. I've got a slide at the end going about that, but just children aren't always brought in as a major trauma, so just to ensure that hasn't been missed on the triage, just to make sure that there's no delays in assessing those children. Next slide, please. So at the Alexandra Hospital, we've got the guideline here for abdominal pains. So I think it's pretty easy to follow, the assessment at the top, and then going peritonitis is seriously unwell, so that automatically will be upgraded to resus or with the consultants in charge. I think that's usually done fairly well because they usually are really unwell. So whatever the cause is, that they often do get escalated quite quickly to start that initial treatment. Possibly the ones that aren't done so well are the ones that have got, you know, some mixed surgical signs, or and that's where we'll just go through a bit more of the assessment and things that we look for. If we can go on to the next slide. So in our Alexandra Hospital flowchart, the red flag signs for surgical problems are any signs of bowel obstruction, trauma, recent surgery, painful swollen testicles, irreducible hernias, and also signs of peritonism. Go on to the next slide, please. So obviously, if they've come in really unwell, then they'll be usually, you know, put up to to go to resus if that's the case. But it's the ones who have not gone that way around on their algorithm. I think present and complaint can sometimes be a bit difficult to elicit. So they will often have come in as abdominal pain, but sometimes they've actually gone to the GP for something else. And it's really okay to just go through the present and complaint again, because actually sometimes that clarifies the situation a bit better. It may be that they've had diarrhea and vomiting for several days and they've got a little bit of tummy pain. So actually their main problem was not the tummy pain, it's actually diarrhea and vomiting. Other things, you know, just trying to make sure that we're going down the right treatment arm so that we can just try and get things rolling as quickly as possible, and also either get people treated or discharged as quickly as possible. I think often the information will change having come from the GP to A&E. I think that's fine, that does happen. So not to be that's why it's really good to clarify what, if there's anything, people will think about things. Even between being triaged in A&E and seeing us, if they've been referred to us, the stories change. That's okay, just to make sure that we just have it really clearly documented, especially if someone's going to need to be transferred to a different hospital. It's really important just to have the clarification of what exactly has brought them in, the timings and things, because often that can be difficult to elicit if they've had to be transferred somewhere else. Paediatric A&Es, you guys are expert at seeing peds. You see them daily. GPs have a very limited time frame to see these children, have the limited resources to do investigations. Yes, they can often do a urine dip. That's probably the maximum they'll be able to do in a short space of time. They don't have the luxury of giving them a bit of paracetamol, seeing them again, reassessing them in half an hour, 45 minutes, that kind of thing. So I think just, giving everyone some grace about those kind of limitations they have is really important. In trauma situations, getting a collateral history if at all possible. Often they will be transferred from their peripheral hospital to a more the tertiary hospital. In those situations, the actual mechanism of injury and the information about that, because people are always trying to stabilize, often is kind of lost in the paperwork. So it can be really clearly, documented in the trauma booklets and that kind of thing. It's really important and helpful for everyone else to kind of, it just gives you that background of suspicion of trauma, or suspicion of what kind of injuries they may have depending on what their trauma mechanism was. And just really clear documentation is really helpful for everybody. Next slide, please. So past medical history is done excellently by all the PEDS team, not always so well by the PEDS surgical team, so we can always learn from that. Past surgical history, not all parents are reliable sources of information. Some are absolutely excellent, others are very vague about what their child has had done, when they've had done, and that can be difficult to convey to the surgical team. So having a look online, if they've got any letters, just to see what and when they've had things done, if you have time, is really helpful. And the surgical history may or may not be relevant. So if they've recently had surgery for difficult appendicitis and they come back in, yes, they may have adhesions, they may have collections. Whereas if they've had something done 3 or 4 years ago, it may not be as relevant. So just kind of trying to put their surgical history into context with their presenting complaint. Stooling habits, we do go on about this quite a lot with children. When did they last open their bowels? Was it normal? Was it diarrhea? Was it constipation? Was it passing when? If they've come in and they've had constipation for a significant period of time, this isn't a new situation for them. However, it might have tipped into a point where they're actually having overflow diarrhea. So just trying to elicit that. And not all of these things will be surgical problems. Sometimes they do end up with us needing manual evacuations, etc. But most of the time, these aren't surgical problems. But really getting a good history really helps. Next slide, please. Again, any urinary symptoms. I've got to put in this bit here as well. So urinary symptoms, especially if they've got a background of any urological problems. So children with known reflux, with duplex kidneys, with any reimplantation, any urological history, really important that we know their urinary results, and if they've had any issues in the past, etc. With girls that are menstruating, having a menstrual history, timing of last period, etc. is really helpful as well. So examination. So I think initially it's just your general impression. So I'm not at the moment. I'm not going through from the like seriously unwell. So this is just general. They're unwell, but they're not seriously unwell. So what's your general impression of the child? Are they sat down? Are they running around? Are they quiet? Are they crying? You know, what does it look like without even putting anything hands on them or anything? And also have a little look at the family dynamics. Often that will guide you a little bit. So about who's the most anxious. Is it the child? Is it the parent? Like, is there anything else going on that seems to be below the surface that's not why necessarily they've presented? Things like family members, oh, my brother had a perforated appendix and almost died, etc. Just little things in the background which may make family, may make them more anxious. It's really just helpful to note. So these are the big signs of severe illness. So surgically wise, severe respiratory distress is pretty unlikely. That's usually going to be coming under the medics, but there are a couple of things, as in if they've gone home and come back. So there's a couple of paediatric things, but they're usually a neonatal problem, so I won't go into those at the moment. Shocked patients for whatever reason, altered consciousness level, that would all go down, be seriously unwell, and they would end up in resus at that point, and that's slightly different. But I'll just go through some of these severe illnesses and things, surgical causes much might cause these. So if we could just go on. So if anyone wants to throw out surgical causes of hypervolemia, be good.
Had a quiet bunch so far, but please do pop it in the chat if you don't want to speak up. That's fine. And Sophia won't mind if we get it wrong.
Nothing? Let's see.
Bleeding.
Okay.
Lovely. Gastroenteritis, somebody's perforation.
Yeah.
Septic shock.
Those hypovolemia. We'll go on to septic shock in a minute. I wouldn't call that a hypovolemic shock necessarily. Perforation again. Yes. Interception. Yeah. Internal bleeding. Yeah. Okay. If we go on to the next slide, I've got some things coming. So hemorrhage is one. So whatever caused trauma, bleeding internally, etc. Gastrointestinal losses. So this is a big one. So children with stomas, especially children with ileostomies, can lose a lot of fluid, even if it's not necessarily a surgical cause per se. So gastroenteritis, they can still lose a significant amount of fluid from their stoma. So especially little children as well, they just don't have as much a reserve. So babies or young children with stoma, it's really important to just try and quantify, if at all possible, with the parents, how much do you think they've lost. And it's not usually easy as to say, oh, they've lost 300 mils or this. It's like, okay, on a usual day-to-day basis, how often do you change the bag? So if they say, oh, I usually change the bag once or twice a day, great. So, but if they've gone up to like 5 or 6 or 7 times a day, and it's more watery and less formed, you just have a bit of an inkling that they've actually lost probably quite a lot, as well as vomiting. And then what will probably happen is they'll stop losing as much because they're a bit underfilled. Gastroenteritis as well, they can lose a lot of fluids, a lot of electrolytes as well. Intussusception, so acting as an obstruction, so they can lose a lot of fluids that way. Volvulus is acting as an obstruction, so vomiting. Incarcerated hernia, again, obstructive. Adhesion, so have they had previous surgery in the past? It's not all, so you can have like congenital bands and that kind of thing, which are a little bit less usual, but knowing if they've had any significant surgical in the past is really important. Pyloric stenosis as well, which I'm sure you guys are very well aware of. Yeah, if we go on to the next one. So surgical causes of distributive shock. So the definition of distributive shock is known as vasodilatory shock. So it refers to systemic vasodilation and decreased blood flow to vital organs, causing inadequate tissue perfusion. So there's what can you think of the surgical causes for this? I know, so someone's already said it earlier. So sepsis will cause this, but the surgical cause is causing sepsis. If we can try and just have a think about those things. Yeah, it's probably less likely, but yes, if they're coming from the outside, but I suppose. So sorry, but not if everyone can see anastomotically. Yes, it's possible. I wouldn't say it's necessarily my first thought. Yeah, so perforated appendix, probably some, yeah, something causing sepsis. Anything else to do with bowel that can cause bowel death, which can cause sepsis?
NEC and neonates?
Yes, so that's one. It's not one I'd necessarily put in the peds one because I'd expect them to kind of be in the neonatal. I think it'd be unusual for them to come from the outside, you know, presenting to A&E with NEC. But yes, that's a good one in-house, if that makes sense. So should we go on to the next one? Next slide. So distributive sepsis. So have you got appendicitis? Have we got ischemic bowel for whatever reason? Is that a volvulus? Is that strangulated hernia? Is that intussusception? Really important one. Hirschsprung enterocolitis. So these children can get very sick very quickly. So they may actually be kind of like slightly sepsis. They may also be hypovolemic as well because of the losses. Another thing that we deal with as surgeons is infected lines. Yes, we may not initially deal with them for their initial period, but we're usually the ones that end up taking it out. But not to forget that these lines they can get quite poorly. So just ensure that you're having a look. Have they had anything done recently? Sometimes abscesses, if they've really been left for a little while and they've got cellulitis, they can get quite poorly. Again, you'd kind of expect them to present a little bit earlier on, but it can still happen. Substructive shock. So this is pretty unlikely in a child. So this is decreased cardiac output because of some kind of physical obstruction that's impeding the blood flow in to the heart and out of the heart. So preloads the fluid coming in, afterloads fluid going out. So it's pretty unlikely in children who have presented. What's the most likely cause of something like this happening? It can be a broad term. It doesn't have to be very specific. So we're thinking about cardiac here. What's stopping blood flow, like obstructive causing? Yeah, so tamponade. But how do you get a tamponade in a child? It's pretty unlikely, isn't it?
Trauma.
Yeah. So trauma. This is pretty unlikely. And children with this, if they have had something like this, the likelihood of them arriving at the hospital possibly is much lower. Anyway, if we just go on to the next slide, sorry. So tension pneumothorax, hemothorax, cardiac tamponade, flailed chest. So those are like, so abdominal compartment syndrome, I guess, but with that, I wouldn't expect that to be like an initial presentation necessarily. I'd expect that to kind of progress over time. Surgical causes of obstructive shock. So trauma. So tension pneumothorax can happen without trauma, so you can have spontaneous ones, but the most likely cause of something like this, which is a highly unlikely thing to happen anyway, is because of trauma. And it's just being aware of them, thinking, why isn't this patient reacting in the way that I think they should? And just having those things in the back of their mind. If we go on to the next slide, please. So if we go on to abdominal examinations, now we all know that children can be difficult at times, especially when they're ill. It's just part and parcel of doing paediatrics. Have they had any analgesia? I always ask that, and I know that sounds really annoying, but it's surprising how much a child can bounce back by having had a bit of paracetamol. Even if they're not completely better, it's much easier if they're not pyrexial, if they've had a bit of analgesia, just to assess them a little bit more, and they're just a little bit more comfortable. Ideally, get them lying down if you can, but it doesn't always work. You just do whatever they will let you do. So if that means holding on to their mum, you examine them from behind, that's just kind of what you have to do. And then trying to, catch them if that means like starting off with, even if they've come in with, some upper respiratory, but they let you touch their tummy, just whatever works, just try. It's not always following the same nice algorithm that usually with our histories. We just do what we can with the children as they'll let us. I usually ask them to point where it hurts first, and that kind of gives you really good. So most children, even young ones, can point to where it hurts. Even if it's vague, sometimes that's actually really helpful as well. They're like, it kind of hurts here. Again, if a child's very well, and you can't see him pointing at my whole abdomen there. If a child's very well and they're pointing to their whole abdomen, I'm not really thinking it's peritonitis. It's pretty unlikely. It's probably something else. If they're sitting there rigid, not moving, and they point to everywhere, I'm quite concerned. Have a look first. So this is where your history is really important because it guides your thought processes when you're examining them. So if you're thinking they're obstructed or something's going on, do they actually look distended? Do they have any signs of obstruction? If they've been in a car accident, can you see any bruising? Can you see a seatbelt sign, etc.? So it's trying to the history is really important to help you with your examination. Try and distract them any way you can, whatever works. So I usually pick, if they're wearing a nice top, I like your top, just really trying to get them talking about something else which is not focusing on their area of pain. A lot of children can be distractible, so you can examine that. They can initially start off, oh, that hurts, but when you're actually talking to them about something they really like, watching a TV program, whatever, they're actually often you can examine them much better, and you may be able to find that actually the tummy's not quite as bad as they first initially seemed. Start away from the most painful part if you can, if it's obvious where it is, just because if you start off, they may not let you carry on. So I usually say to them, I'm going to start off, far away, just let me stop, just stop me if you don't want to. Of course, not everyone's going to let you examine them, but you just do what you can with the kids. If we go on to the next bit. So examine with purpose. I know I don't want to sound that patronizing, but we can examine the tummy, but just in our back of mind to remember the anatomy that we're feeling for. So what's the history pointing at? And with your examination, is the history, you've got some differential diagnosis in your head, is your examination fitting in with that history, or is it pointing you to somewhere else, which you might have to clarify with the history a little bit later. So I think it's just about, in one way or another, not being too narrowed down, but also trying to narrow yourself down. You don't want to be blinded to, oh, this was abdominal pain, it's definitely appendicitis. But then again, children can present a little bit vaguely, especially the younger they are. So not saying, oh, well, it's definitely not completely in the right iliac fossa, so it's not appendicitis. So just kind of trying to fit all those pieces together. And don't forget to examine other relevant areas. So ENT especially, I've diagnosed quite a lot of tonsillitis, pneumonias, chest infections, that kind of thing. So just, again, history. Have they had a cough? Have they had a cold? Have they had respiratory symptoms for the last few days and then had some tummy pain? Don't forget those bits, because actually that in the last little bit, that's what they've been unwell of. Their tummy pain may be secondary. It might just be mesenteric adenitis. Again, that's a diagnostic exclusion, but still just kind of have it in the back of your minds that this might not just be their tummy. Don't forget the groins. That's really important. If they've got tummy pain, you need to look at their groins. Do they have any lumps? Do they have any bumps? Have those been there before? With boys, have they got bilaterally descended testicles? It might be the first time anyone's noticed they don't have one testicle down. Just really important just to document it. It may have absolutely nothing to do with what they've come with, but it's just really important, because we do have children turn up years down the line who are like, oh yes, nobody's noticed they don't have a testicle like in the correct place. Just not and referred pain with testicular pain as well. It can be referred, they can get low abdominal pain. If we can go to the next slide. So listing peritonism. So I think this is quite a difficult one. So people are like, oh, they're peritonitic. So it is a very good sign for appendicitis, especially with patients who've got it in the right lower quadrant. Rebound tenderness and guarding, from the literature I've seen, it's got kind of a poor inter-rater reliability. And also things change. So just because they seem like that initially without any analgesia, it's actually really reassuring that when they've had a bit of analgesia, they feel much better. So things changing is not a problem. It's just, it can be difficult the more experienced you are to what you would say is guarding and what's voluntary guarding. It can be very difficult to pinpoint that, which is why it's important to have all the other things going together. Does the history fit? Do they have any other symptoms? How long's the story been going on for? The guide, with doing the scoring really helps, because it tries to make some of these more elusive, like rebound. You can't fake a temperature, you can't fake a CRP or but it can be difficult with a child who's not compliant to examine them fully. Again, I've said this before, but please give them some analgesia. Even if you've just got to see them and they're in lots of pain, give them some analgesia. Even if you're going to refer to the surgeons, it's really, really helpful, because what we'll do is we'll come and examine them, unless it's barn door and they're really sick. We're probably going to give them a bit of analgesia, and we're going to come back and examine them again. One good I found really helpful is do the jump test. So I'm quite short, so I usually challenge the children to get out of bed and see if they can, touch my hand. I'm like, I'm really short. I'm sure you can jump higher than me. If a child can get out of bed and jump, it's pretty unlikely they've got any peritoneal irritation. So you give them a challenge. Children that don't want to get out of bed, fine. You can't make them if they're not feeling well. Well, why ask them to give you a really big cough? I have to say, some children don't understand this, and that can be tricky. But most children know how to go, and they can really you can get a lot of information from that. And repeat examinations are fine. That's what we end up doing a lot of the time. If we're not sure, give them a bit of analgesia, give them a bit of time. If they've been vomiting a lot, give them some fluid and re-examine them and see what we think. If at that point we're still unsure, then we can always use the ultrasounds, etc. if we need to. If we go on to the next slide. So subtle signs of being quite unwell. Just being quiet. Now, some children are just quiet, but a child, they're just not moving very much, very reluctant. They look quite pale, they're very flushed. They're just not quite themselves. They're off their food. And parents are like, this is just not them. I just have a higher suspicion. So children tend to not sit still. Even if they're not, running around, they tend to be wanting to do something, playing with a toy, doing something. They don't often want to just sit still. So just, subtle things. go on to the next slide. Oh, okay. So I know people know where the anatomy is, but I'm just going to go over a few bits and pieces. So the appendix, we say right iliac fossa, but actually where the appendix can sit in lots of different places. So yes, most of the time, unless they've got any malrotation, yes, it'll be around the right lower quadrant area. But actually the tip of the appendix can sit in quite a lot of places. So sometimes it sits down in the pelvis, sometimes it can be up subhepatic, so it can sit in lots of different places. Don't be fooled by the pain being in a slightly different place. Try and go with the whole picture. Another thing that they can present with is diarrhea. They can get quite a lot of rectal irritation with an appendicitis which is down in the pelvis. Another thing is younger children, as you can see here on this side in the middle picture, the omentum is a really big flap of fat, and often as they're older, it's quite a developed thing, and it will often wrap the appendix and stop it becoming such a free peritonitis and free abscess. However, younger children have quite a small, underdeveloped omentum, so they don't tend to wall off in the same way that older children will, so they can get quite sick quite quickly because when they perforate they don't tend to wall it off in the same way. So, and the younger children as well, they're not as good as telling you. Their signs are a little bit more subtle, they have less reserve, they're just smaller. So yeah, just to think that probably is right iliac fossa, but don't forget about the other places that it can sit as well. Next slide, please. Constipation, this is like the big one. So a lot of the time children have constipation. It can be chronic, it can be acute on chronic, it can just be an acute problem. Most of the time it's sitting on the left hand side. Sometimes you can feel a mass. That's what's really important to get a stooling history. When do they last open their bowels? Has it been easy, etc. If you can feel a big mass on this side, but it's indentable, even if they're a little bit uncomfortable, it's pretty unlikely to be something major. If they've had chronic constipation and they're known to have, they can actually have these rock solid things in their pelvis. So yes, it will feel like a really hard mass. Pretty unlikely that that's going to be fixed with just laxatives, but it's just something to be aware of when you're feeling it. Where are you actually feeling this area? Is it just trying to elicit the part of the bowel that you're feeling? Next slide, please. So referred abdominal pain, don't forget testicular examination. So you can get lower abdominal pain just from testicular torsion, so really just make sure that you check. This is done usually pretty well. So, but yeah, just not to forget, and just document it as well. It's really important to document these things just for your own, what's the word? Backup, shall we say. Next line, please. So ovarian causes of pain. So ovarian torsions, often quite a sudden onset pain. They can be really quite severe, vomiting, nausea. But then again, they can also have Mittelschmerz as well, so it could be their mid-cycle and they're getting some pain. Ovarian cysts as well, hemorrhagic cysts as well. So just trying to get, if they are pubertal, prepubertal, just getting an idea of where they are in their cycle. It just gives you a bit more of a inkling to see if you think this might be a gynecological cause. So hernias, this can be quite a difficult one to, if you're not used to examining children. So a child with a hernia isn't necessarily a surgical emergency. If a hernia is fully reducible and they don't have any other symptoms, this is something that needs to be fixed, but it can be fixed. If it's a younger child, often we'll try and do it urgently. But it's not necessarily an emergency. Things that we don't want to miss are stuck hernias. So I don't know if you can see these pictures. They're so they don't look significantly different. I'd say B looks probably a bit big, but with this one, number A, you can see the intra-abdominal findings. There was a bit of ischemic bowel. The second child, the bowel was stuck in the inguinal canal. And again, in C, it was stuck as well, but there was no edema. It came out quite easily. It's just about trying to fit all the pieces together. So is this lump new? Have they seen it before? Have they got any other associated symptoms? Are they vomiting? Have they got signs of obstruction? Are they uncomfortable? In babies, it can be really difficult, but just trying to elicit the rest of the story. What's the other thing I was going to say? Yes, it can be really difficult to tell the difference between a hernia and a hydrocele. So hydroceles can sometimes be quite big, but trying to get a bit of the history. So a hydrocele, if it's a communicating hydrocele, it will often go up and down throughout the day. So do they sometimes see it there, sometimes not see it there? Has it been there the whole time? Is it tense, etc.? Again, there's no harm. If you're not sure, I'm really happy. I'd never say no to seeing one of these patients because it can be really hard if you're not used to it. So give us a call. That's what I'd say in those ones. It can be really difficult. What we just don't want to miss is a stuck hernia, but I think we'd rather see a couple of hydroceles rather than a stuck hernia and the complications of that. We just go on to the next slide. So on girls, it can look a little bit different, obviously, but again, a little bulge. Sometimes they have the ovary stuck in there, so sometimes you can feel something palpable going in and out. It's just a bulge. They don't. Getting parents to show you pictures, often they've got them on their phones. Just say, oh, when have you seen this before? Have you got a picture, etc. So yeah, they can look a little bit different in girls, but again, they can still, these here are just showing ovaries in the hernia, but again, they can have bowel as well, but it is more likely in boys. Next slide, please. Interception. So another bowel issue causing obstruction. So it's when the small bowel, most of the time it's ileocecal, so when the small bowel telescopes into the large bowel and acts as a point of obstruction, so they get proximal small bowel dilatation. On here you can see that little tummy, apparently that sign's the dance sign, where they've got where the small bowel has made its way round and has left the right side of the abdomen empty. So again, these kind of things, if you put it together with the history, is really, that's where we're trying to put it all together with the history. If you're waiting for things like red jelly stool, etc., those are quite late signs. We don't really want to be getting to that point. So if there's any concern, trying to get an ultrasound urgently is really useful. Again, if you can't get that to your local hospital, then have them transferred somewhere that can do that. Next slide. Gastritis, so upper abdominal pain. Children, when they have vomiting, they can have non-specific tummy pain, but if they've had a lot of vomiting, I would personally give them a bit of a PPI and see if that makes any difference to some of the symptoms. But again, it can be usually a diagnosed exclusion. Next slide. Cholecystitis and pancreatitis. So these are uncommon in children, but they are becoming more common. So the most common cause of pancreatitis is gallstones. Right upper quadrant pain, epigastric pain. Don't forget, if their pain's upper, or actually any abdominal pain, make sure they're getting an amylase and LFTs. Again, it's less likely, but they are becoming, as children get a bit bigger, they are becoming more common, having issues with gallstones and the subsequent problems that those can cause. Go on to the next slide. So bowel obstruction. So when we get lots of phone calls about children who've got bilious vomiting, and we'll go through that in a second. Progressive vomiting. So sometimes children will have bilious vomiting, which is normal. So things like when they've been vomiting, so just getting a really good timeline. Have they been vomiting? and then not being able to eat and drink anything, lots and lots of vomiting, and then it becomes bilious? Or is there signs of obstruction? So have they got bilious vomiting with not opening their bowels, not passing any wind, abdominal distension? And then thinking about, okay, so if we think they're obstructive, why are they obstructive? Do they have an appendix mass? Again, it's unlikely to be a short history. It's something that's going to be a longer history. They're usually unwell. They've got, localized peritonism. They've got inflammatory markers. Do they have intussusception? Have they got this like colicky, intermittent abdominal pain? Have they got obstruction because of previous surgery? So just really, have they got a volvulus? Again, it's trying to put it together with the picture. And have they got an incarcerated hernia? Just really important to check the groins. I think, can I just go to the next slide? I think. So things that aren't obstructive symptoms by themselves, diarrhea and vomiting. So a child who's got a lot of diarrhea and a lot of vomiting, or a lot of vomiting but is passing stool, it's not a sign of obstruction. So just trying to like elicit all those things together. You can have stool opening and still be obstructed because you're what's the word? You're emptying the lower part of the obstruction. But again, these don't tend to be quick symptoms. They tend to have progressed over a period of time. So getting a really good timeline of the history is really important. If we go to the next slide. Oh yeah, so this is a nice BMJ chart. So where would people say, what colour is bilious vomiting? What numbers from where would you say is bilious vomiting?
Have we got everybody still? Just go for a number.
Any number.
7 and 8. 5. So somebody's gone for the darkest green and somebody's gone for the first green. Sue thinks from 3. 5 to 8. 4. Put us out of our misery, Sophia. Everybody thinks something different.
Next slide, please. So 5 to 8 would be considered bilious vomiting. So this is in the BMJ paper, and I actually, in previous hospitals that I've actually worked in, we've had these printed off as cards to be, to hold up as like a standard. It's like, okay, what is bilious vomiting? And bilious vomiting can be for various reasons. I guess the one that people are most concerned about is one that nobody wants to miss. And does everyone want to say, what is it about bilious vomiting in a baby that you would be really concerned about? Anybody? Okay, we'll just no. Okay, we'll go through that in a second. Okay, next slide, please. So Emily, yes, duodenal atresia. However, I wouldn't have expected a child to go. So this is where we're trying to say children that have come into A&E. I'm not trying to talk the neonatal period because that would be a little bit unfair because that adds in a lot of congenital things. So I'm thinking children that have come home and have presented to the hospital, unlikely they've got duodenal atresia unless they've gone home extremely quickly and not fed, which I think is pretty unusual in the neonatal ward. Well, one I'm really concerned about is malrotation. So normal rotation, you've got the large bowel, you can see just kind of going in that shape, and it's kind of fixed on the right hand side and the left hand side. In malrotation, the bowel doesn't sit in that particular way. So what happens is, it's quite difficult to explain if you haven't seen it, but the small bowel does not sit in its normal mesentery. So usually the mesentery sits nice and wide and it's unlikely to twist on itself. In malrotation and volvulus, because of the way that the bowel has made itself, it has quite a small mesentery. So the mesentery is where the blood supply goes, and it can twist on itself. And the really catastrophic thing with small bowel malrotation is that it actually can take out pretty much all of the small bowel. So children are left with like really awful small amounts of bowel, and that's just catastrophic for them and their families. So we do get a lot of referrals for query bilious vomiting, and I think it can be really difficult. So I think first thing to do is, are you sure it's bilious vomiting, number one? So trying to, like, you know, have a look at that. And the reason why it's that you get bilious vomiting is because the obstruction has come from past where the bile gets into the bowel, which is D2-ish. So that's why it's bilious. However, if we're talking about pyloric stenosis, the actual, I'll send you a picture afterwards, is that the obstruction is before you get to the where the bile comes into the bowel, so it's non-bilious vomiting. So that's slightly different, and they tend to have a different kind of history. So just to be aware, small babies, actually even older children with unusual bilious vomiting is a possibility. So sometimes they don't appear until a bit later, but that is unusual. It tends to be in the first few days of life. Bilious vomiting in a small baby, we need to rule out malrotation and volvulus. Okay, next slide. The pyloric stenosis. So this is, can you see my arrow?
No.
Oh, okay. So for the anormal, so the reason why it's non-bilious is actually the obstruction is just on the outlet of the stomach. So you can see enlarged pylorus. So the bile comes after that. So when you're vomiting and you've got pyloric stenosis or gastric outlet obstruction, you're not vomiting anything with bile in it, because actually the bile's not able to come back into the stomach from the small bowel. So that's why it's non-bilious vomiting. So, and the story tends to be different. So with a malrotation, tends to be they started feeding and then they vomited and had bilious vomiting quite quickly. With pyloric stenosis, they tend to start off a bit more, you know, have they got reflux? Have they not? It kind of is progressive, and then it gets progressively worse, projectile vomiting, but non-bilious. They often have quite typical gases as well, and the babies look quite, unless you catch early, they often look quite scrawny. They've lost a lot of and they're failing to thrive. If you plot them on their chart as well, they've often lost a lot of fluid. They haven't gained any weight. It's quite a typical history. You should be able to feel it, apparently. I have to say, despite all of that, I can say I don't think I've ever felt the pyloric mass without the baby being asleep. So don't feel bad if you can't feel it. Just go on this history, go on the bloods, and we'd usually get an ultrasound. Next slide, please. So just going on to other bits of like surgical children. So major trauma is most common. So we did a recent BAPS trauma day, and going through some of the information they gave us, it's actually trauma is most common in the first year of life. 50% of these children are actually under 5 months of age, and that's in the Town Report 2022. The first 3 months having the highest incidence. So, and suspected physical abuse, non-accidental injury accounts for about 10% of major trauma in children. And what's really interesting, which I hadn't really thought about, is a third of the trauma patients being brought in brought in. So basically they're scooped up by their families or whoever, and they're brought into the hospital. So they're not announced as a major trauma. And I think that's sometimes where things go a little bit wrong. So if someone's brought in by ambulance under the major trauma, often that does go along the right pathway. They're going, you know, they get all the scans, everything they need to have done in the right order. If that's why I was saying right at the beginning, so if they've had triage and there's like and someone says actually they've fallen out of a tree, that they've been hit by a car or something like that, just to have that, okay, actually, is this a major trauma? Is this something that we need to escalate, and make sure that we're going along? And just because the trauma pathway booklet is very comprehensive and actually takes you through everything that you should be doing, And things not to forget as well, if you've got someone with any signs of bleeding, please get 2 group and saves. It's really helpful, just because if they need any blood, it just, you're saving time rather than to think about it a little bit later. If you don't need them, fine, but it's really helpful. So just to not forget about that. Third trauma patients brought in unannounced. Next slide. So I was also asked to speak a little bit about children who have non-verbal children, but it's just to highlight a group of children that we do come across. Children with Down syndrome tend to are often a higher risk group. They often get more severe infections and can have poorer outcomes. This is because they often have underlying conditions. They often will have cardiac conditions. Some of them will have Hirschsprung's disease, etc. So there's lots of underlying conditions to these children, and often they just don't deal very well, and for whatever reason they don't always exhibit pain in always the same way. So just to be very cautious about these children. They just have possibly a lower threshold for escalating if they're not quite right. The parents know them best. I would just be extra cautious with this group of children. We'll go next slide. Non-verbal children as well. They can be extremely difficult to assess. They often have a lot of other underlying conditions. The parents and the carers are the best source of information. What is it that has made them come in? What's different for them? Like, why are they unhappy? What's happened? It can be really challenging. I think it's just reassessing and having possibly a lower threshold. So if an ultrasound's not diagnosing a child who looks like they've got some kind of abdominal pain, I think the threshold of going for a CT is often, or should be possibly, a little bit lower, because it's trying not to miss these appendicitis and what else have I seen, like gastric vulva. There's all sorts of odd things that can happen in children just that don't always present in the same way. They don't have the same, it's difficult because they don't have the same symptoms, so they might not eat very well. They might be on feeding tubes. They might have reflux. So actually, is this worsening reflux or is this like new vomiting? It can be really difficult to elicit between all these different things. So just having a lower threshold for these children, about investigating a little bit further possibly, because you don't want to miss anything. Anything else? Next slide. Yeah, so I think someone spoke about it before. Ultrasound is usually the first imaging modality in most cases. However, second line, I guess it depends how confident you are your first ultrasound. So if there's non-diagnostic, would you do another ultrasound or would you go for a CT? I guess it really depends on the child. It depends on the situation, and I wouldn't necessarily be expecting that to happen in A&E. I guess that's something that needs to be more thought about on the wards if someone's been admitted and they aren't improving. Just making sure that you just think about missed causes of whatever's going on with them. Next, please. Oh, just going a little bit on bits that often people find quite just part of paediatric surgery that people just don't seem to know masses about. So just showing you a picture here of balloon enteral devices. So a lot of our children, especially ones with more complex needs, they'll need some kind of enteral feeding. So the ones I'm showing you here are balloon devices. Now, I don't want to be a pedant, but sometimes it gets quite difficult when someone says, oh, they've definitely got a peg. And I'm like, are you sure they've got a peg or have they got a balloon? So just trying to get the terminology right, because it just makes a slight difference about something. The really important things are, how old is this? Have they had it done recently? If this is 3 or 4 or 5 years old and it's come out, I'm really not that concerned. We can really usually just put it back in, and it often doesn't need to come to a surgical centre or anything like that. They act a bit like catheters, so the balloon's inflated within the stomach, but it's going along the tract which has been formed. So it's a bit like, when you've had an earring done, there's a tract that gets formed. But within the first few weeks, it's not very well formed. So if it comes out in those first few weeks, I'd be very careful about restarting feeds or anything without being sure that's in the right place. After a couple of weeks, they've often been changed in the community. It's often not a problem. So these are the balloon gastrostomy ones. These go into the stomach. If you look below here, the one in the bottom right-hand corner, that's a core flow balloon. It's still a balloon gastrostomy, so it's no different to the one above it. The only difference is that it's got a slightly longer tubing on the outside. And sometimes we will start off with these in surgery, and then move over to the button balloons, which are low profile. The same on the left-hand side. So this is another balloon device, but this balloon device has got a jejunal extension to it. So if you look here, it's got two different ports. It's got the balloon port. Oh, it's got three different balloon ports, so that inflates. The feeding port cover for the gastric port and the jejunal port. So lots of children will often go from this the gastric one to this jejunal one if they have difficulties with reflux and stuff. So just like they are very good and people like them a lot because they've been changed in the community. However, they can give lots of problems. They can leak, they can fall out, they can be misplaced. The jejunal extension port can flip back into the stomach. There's lots of things that can go wrong with them. But most of the time, they've been there for quite a while, so it's unlikely they're going to have like a surgical problem if it's been there for a while. I'm not saying it can't be, but an established one is, they're usually quite safe. If we go to the next slide. So these are slightly different. So these are pegs. So traditionally they were put via what was I trying to say? Sorry, they just put in with having a gastrostomy and put in blind, so that you end up in the stomach and then you pull through. So you don't do it laparoscopically, whereas a lot of the time nowadays, if you're doing a primary button gastrostomy, they're done with a laparoscopic done keyhole as well, so that you are ensuring that you're suturing the stomach up to the abdominal wall and that you haven't caught any bowel in between. So just the force needed to pull one of these out is much higher. So if someone has had a peg and they've been pulled out early on, I would be quite concerned, because actually the amount of force that's needed to pull that out, because it's not a balloon that's burst and it's just coming out like a catheter that's been deflated. This is like a little round kind of thing being pulled through the hole. If that happens, I'm quite concerned. And also if there's a problem with these, to take them out, you often have to do an endoscopy to pull them out, because this disc won't. You can technically pull it through, but most people wouldn't. So you need an endoscopy to take it out. So it's not just, oh, we'll just change it. They're just having a bit of terminology that this is a peg, the other one's a balloon device. And if you can find out what they've had done, if you just go back a second to the previous slide. So on the sides, usually they tell you what size they are. So the French is how wide they are, and the number saying 1.2, 1.3, 1.4. So that's the depth. So that's how far it is between the abdominal wall and the inside on the stomach, and they will vary over time. That's another thing that can sometimes catch people out, is they start off, especially someone who's not been feeding very well, they can start off at quite a small one, but as they get fed and they put on weight, people are going, oh, we're having trouble with this balloon. You're like, actually, it needs to be resized. It has to go up because they put on weight, which is what we want them to a lot of the time. They're just things to think about. They're not, just because they've got gastrostomy doesn't mean like that's a surgical problem. But in the first couple of weeks, I would, if something comes out, put a catheter in it, give us a call, and we can go through things. What's the safest thing to do in that situation? Can we go? Have I put anything else? Yes, that's fine. I've said that already. I think that was it. So that's just a whistle-stop tour of things to think about when you're assessing surgical patients. So I hope that's not too patronising. I'm just trying to get people to just think about when they're examining, doing the history, like really kind of narrowing down where their examination is going and trying to fit that up with the history. And children are difficult, and it's not always standard, but most of the time, if you put the examination together with the history, you usually get to kind of the ballpark of where things are going.